Here with Tonia Mezzini, who's a sexual health physician. We're at RANZCOG 2018, the annual scientific meeting. So Tonia's just given a very popular presentation.
Bit of light relief.
A bit of light relief, yeah. Sort of acting out, I guess, a scenario in which a GP has an encounter with a 16-year-old girl. And I guess the broader issues were that, you know, adolescent health and adult health, sexual health are very different things. So can you talk us through a little bit of what you talked about in your presentation?
Okay, so the brief that I had for the presentation was to talk about contraception, STIs and sexual health in young people in 20 minutes, which is a pretty big ask. And I didn't think that a talk that was just going to run through a whole set of statistics was going to be particularly helpful, because we all know the statistics and we can read them easily, but what I thought would be most useful if gynecologists are looking at expanding their scope of practice and starting to work with younger people is the different skill set that you need and the different approach. Broadly speaking, the skills that you need to deal with an adolescent consultation and for that to go well are not really dissimilar to what happens with an adult, but the focus is a little bit more intense. So it is reasonable, whether you're talking to an adolescent or an adult, to have good manners, to introduce yourself, to be warm, to be friendly, to be engaging. That applies to whoever you see. With adolescents, it's very much about their agenda up front, and if you're not addressing their agenda up front, then they rapidly lose interest and disengage. And that happens to an extent with adults, but adults tend to know what the rules of engagement are for a consultation, and they'll so go along with things a little bit more. What we did in this presentation was based on a teaching style that I used when I was a registrar, where to demonstrate good doctor, bad doctor, myself and Lane, who's a registrar, would do sexual history taking and do it really badly, and then do sexual history taking and do it really well as a way of demonstrating rather than just explaining how to do this properly and what the pitfalls are.
Yep. So some of the things that you said were, you're not cool, get
yeah,
over.
You're not cool, ever. One of the things that I think people make the mistake of assuming is that dealing with young people that you have to try and, you know, be down on their level and get with the program and use the jargon, and you can't, because you just look like an idiot, and that really alienates young people. It's a bit like parenting in the sense that, you know, you need to be friendly, but you are not their friend. And you actually need to be the person that they know that they can get consistent, reliable, safe advice. And so being cool and being their friend is not actually what you need to be. And you're just not cool anymore. Just face it. You might have been 10 years ago, but you're not anymore. You're positively geriatric, really, you know, when they're 15 and you're 30. What else did we talk about? We talked about using the third person as a way of raising questions that are difficult. It's a really good sort of deflective strategy. So if you need to ask something that's awkward, rather than saying directly, you know, is this happening to you? You can say, look, for some people who are your age, they're often thinking about their gender, they're thinking about their sexuality, they're thinking about relationships. Is this something that you've been thinking about? Or you say, you know, often people at your age are thinking about starting to have sex. Is that something that you've been thinking about? And that's a little bit less off-putting than saying, are you having sex? What are some of the other things that we did?
Well, there was an interesting discussion that happens among the panel about whether it's time to put this stuff properly on the curriculum. I'd be interested in your thoughts on that and on the current state of affairs in Australia regarding that.
Okay. Abso-frickin-lutely do we need to have a good sex and relationships education program in all schools, public and private, with teachers adequately resourced to be able to present that information. There is an overwhelming body of evidence that shows that in countries where kids get sexual health and relationship information from an age appropriate level, you know, so starting in primary school all the way through their adolescence, they have lower rates of teenage pregnancy, lower rates of STIs, and generally do better on all sorts of sexual health outcomes. One of the things that's particularly sad about the abolition of the Safe Schools program is that it's just a a terrible failure to acknowledge that a lot of mental health issues for young people are around sexuality and gender diversity. And to ignore that, well, we've got an article in the MJA from only this year saying we've got all of these young people presenting to emergency departments in distress. What's going on? And then they cut Safe Schools program. I mean, what's going on there? I don't understand how that broke down.
There was some commentary on social media during the discussion about, it's really the place of ONGs and the college and specialists like yourself to be political about this sort of thing. What's your view?
Well, it's difficult to be political apparently while you're employed by a public hospital. I'm not employed by a public hospital anymore. And I think that, there are ways that we can be gradually political, and certainly, presenting at conferences and being involved in what is presented at conferences is a way to kind of get that groundswell of opinion and information out there.
We haven't really got into it in too much detail, the transgender health issues, but I know that that's an area of interest of yours. How is that playing out in Australia currently?
Well, most states in Australia have a publicly funded gender unit. South Australia doesn't. So we don't have an adolescent unit, nor do we have an adult unit.
That's incredibly difficult for people who live here, yeah. So what do they do?
So it means that they end up seeking help through the private sector, and most of us who work in the private sector don't charge for our services in order to make a review with a sexual health physician or an endocrinologist financially feasible for people.
And how does the political, landscape around this issue interplay with the health system?
My impression is that people just want to ignore it and hope that it'll go away. If we don't talk about it, it's not happening. I really do struggle to understand it. Having grown up in the Dunstan era and going through medical school thinking that my career would be in the public sector, working in sexual health, and I've ended up working completely in private practice where I have autonomy. And I can, expand my service as I like, and if I choose not to charge a gap for those services in order to make them accessible, then that's what I do.
It's not a great place to find yourself in.
Well, it's just sideways. But it would be nice if it wasn't just sideways.
Yeah. Well, it's been great to talk to you. I really appreciate your time. Thank you.
Thank you.